You have been doing something wrong in the bathroom your entire life, and you had no idea about it. Hard straining on the toilet can trigger the very same cardiovascular stress response that cardiologists use on purpose to test how your heart functions. And sitting on the toilet with your phone for 10 minutes, even after you are already done, is one of the most reliably documented ways a person develops hemorrhoids. These are not horror stories meant to scare you. They are just biology. And once you understand what is actually happening inside your body, a few simple adjustments end up changing everything. If clear, honest health information is what you came here for, subscribe and hit the like button right now. It helps more people find this channel, and the goal is 300,000 subscribers. Scan the QR code on screen to join me over on Telegram. That is where I post checklists and practical health content you can actually put to use. Let's begin with what happens the moment you feel the urge to go. Your large intestine, the colon, has been quietly contracting all morning long, pushing its contents toward the rectum using smooth muscle tissue. Smooth muscle is the kind that works automatically, without you thinking about it at all, just like the muscle inside your blood vessels. That urge you feel is your body's signal that it is ready to go, and your only real job is to not stand in the way of it. Here is what happens when you ignore that signal and decide you will just wait until you get home. The rectum stretches to hold the incoming contents. The stretch receptors inside the rectal wall, the nerve endings that should be telling your brain, time to go right now, slowly adapt to the increased pressure they are under. Over time, they stop sending you that honest signal unless the rectum is genuinely packed full. That is the beginning of chronic constipation. Infrequent, hard, painful stools. Pelvic floor specialists note that long-term suppression of the urge frequently shows up alongside pelvic organ prolapse and pelvic floor dysfunction, one problem dragging the next one behind it. This is actually a pattern that comes up in primary care records more often than most people would ever guess. A patient with significant constipation who traces the habit back to years working in an office where leaving the desk felt like a problem. So the rule is simple and unglamorous. When the urge shows up, you respond to it. Situations exist where a bathroom is not available. That is life. But when "I will just wait until I get home" becomes your default every single day, you are training your bowel to need to be dangerously full before it bothers to signal you at all. Now let's talk about the cardiovascular piece, because this one really surprises people. Hard straining on the toilet is physiologically identical to something cardiologists call the Valsalva maneuver. That is when you take a deep breath, close off your airway, and push hard against the closed glottis, the flap at the top of your throat. In that moment, pressure inside the chest spikes sharply, venous return to the heart drops, meaning less blood is flowing back toward the heart, and the baroreceptors inside your blood vessels scramble to compensate. Baroreceptors are pressure-sensing nodes inside your arteries. They help regulate your heart rate and blood pressure moment to moment. For most people with healthy hearts, this brief pressure event passes without incident. But in someone with undiagnosed heart failure, a serious arrhythmia, or advanced atherosclerosis, hardening of the arteries, that very same event can trigger fainting, a dangerous rhythm disturbance, or worse. Medical literature has documented cases where the act of defecation was the precipitating event for a cardiac emergency in people who already had a compromised cardiovascular system. The toilet itself is not dangerous. The combination of aggressive straining, a difficult posture, and an already stressed heart creates unnecessary risk. The goal is always to make this process as effortless as possible for you. There is a well-documented footnote in this story that makes an even simpler point. Industrial incident records contain a case involving a factory worker who manufactured equipment for submarines. He brought home a chemical kit that released oxygen on contact with water, essentially a compact oxygen generator. He emptied it into the toilet bowl, left the room, then came back and lit a cigarette while seated on the toilet. The oxygen-enriched atmosphere ignited. The incident sounds almost absurd, but it illustrates a straightforward point. Smoking in the bathroom is not just a bad habit. It is a potentially dangerous combination with any chemical agent, cleaning product, or reactive substance present in that space. Setting aside the exotic case, nicotine constricts blood vessels and drives up the heart rate. On the toilet, where the cardiovascular system is already handling fluctuating pressure from straining, adding a nicotine spike on top is a compounding factor. For someone with existing heart disease, retinal damage from hypertension, or vascular compromise, the combination of hard straining, a pressure spike, and nicotine is worth discussing with a doctor before the next cigarette is lit. The short version: at minimum, it is worth asking yourself whether the bathroom is really the place for it. Let's talk about phones for a minute. Scrolling through news, watching videos, reading articles, all of this stretches the time you spend seated on the toilet, often without you even noticing it. Clinical observations consistently link prolonged sitting on the toilet, particularly with low-level repetitive straining, to hemorrhoidal disease. Hemorrhoids are enlarged, inflamed veins inside the rectal wall that protrude, bleed, and cause pain. Think of them as the varicose veins of the rectum. The longer you sit there, the longer those veins remain under pressure from the weight of your body and the position your pelvis is in. And when your attention is fully absorbed by a screen, you lose track of whether your bowel has actually finished what it was doing. The stool has already passed, but you just keep sitting there and scrolling, continuing to load the venous network of the pelvic floor. Pelvic floor specialists increasingly list prolonged sitting on the toilet and the smartphone habit that drives it among the modifiable risk factors for hemorrhoidal disease. Human beings evolved squatting briefly in the open air and then moving on with the day. Our rectums and pelvic veins are built for short, efficient events, not extended sessions with a news feed. Now let's get to the most damaging habit of all: forcing it. Prolonged aggressive straining drives intra-abdominal pressure, the pressure inside your entire abdominal cavity, sharply upward. That pressure does not stay confined inside the rectum. It distributes across every structure inside the pelvis: the bladder, the uterus in women, the prostate in men, the ligaments, the connective tissue, and the muscles of the pelvic floor itself. After years of this kind of repeated load, especially in women who have delivered children vaginally and in anyone with connective tissue weakness, clinicians document pelvic organ prolapse, rectal displacement, and a condition called rectocele. Rectocele means the wall of the rectum has pushed through and begun bulging into the vaginal wall. In advanced cases, the tissue actually protrudes outside the body. That is surgical territory and involves a different kind of specialist conversation entirely. Beyond the mechanical damage, chronic straining and constipation are closely linked to pelvic floor dysfunction. The pelvic floor is a hammock of muscles at the base of your pelvis that should relax during a bowel movement, opening up the exit pathway. In pelvic floor dysfunction, those muscles do the opposite of what they should. They contract at exactly the wrong moment, fighting the process rather than helping it along. Research reviews note that among people with chronic constipation, a significant proportion have pelvic floor dysfunction as a contributing or primary cause, not just a lazy bowel. The result is a cycle that locks itself in place. You strain harder, the muscles tighten more, and the evacuation becomes worse with each attempt you make. Let's talk separately about hemorrhoids because the mythology around them is still extraordinary. People still believe that sitting on a cold surface, eating spicy food, or catching a chill is what causes hemorrhoids. Current evidence consistently points somewhere else. Chronic constipation, straining, excess body weight, pregnancy, physical inactivity, and possibly genetic predisposition to connective tissue laxity. The causal chain is not always perfectly linear. Bodies are complicated, but if you have spent years straining hard for 10 minutes on the toilet, sitting still most of the day, and eating a low-fiber diet, the cumulative risk is genuinely elevated. Changing the cold seat mythology helps absolutely nobody. Understanding the straining and fiber piece is actually actionable. Now let's discuss posture, because this is not as simple as just sit differently. At the exit of the rectum, there is a natural bend called the anorectal angle. In a typical seated position on a Western toilet, this angle is pronounced, which is actually useful day to day. It helps maintain continence while you go about your normal life. When you squat, that angle straightens out and the contents of the bowel can pass through more easily. Human beings spent thousands of years squatting, not sitting on elevated fixtures. A study with roughly 30 healthy participants had them use the toilet in 3 different positions: a standard toilet, a lower toilet, and a full squat. People in the squatting position reported shorter time to complete evacuation and less subjective straining effort overall. Separate work using radio-opaque contrast has shown that the anorectal angle straightens more completely in a squat than in a seated position, meaning less muscular effort is required to complete the process. That said, recent systematic reviews are careful to note that the position evidence remains limited in volume, and posture is just one variable among diet, hydration, activity, and medications. This is not a reason to climb up onto the toilet rim. It is a reason to consider whether a simple adjustment might be worth discussing with your doctor if evacuation is already difficult. Here is the practical part: what to actually do when the urge is there but things are not moving easily. For most people with a healthy diet and soft stools, a standard seated posture works just fine. Sit upright, feet flat on the floor, torso leaning slightly forward. If the stool is hard and fragmented, sometimes called skybulous, meaning pellet-like, and the bowel is working hard, a few techniques from clinical practice are worth knowing about. The first technique is changing your torso angle. Some people find that leaning forward with elbows resting on the knees relaxes the pelvic floor and helps the process. Others benefit from a slightly more upright and rearward leaning position, back resting against the tank or wall, which shifts the rectal position and can add a little gravitational help without brute straining. The point is not to find one perfect formula, but to explore what reduces the force required. The second is elevating your feet. Placing a stable step stool or platform under your feet raises the knees above hip level, tilts the pelvis, and straightens the anorectal angle closer to a squat position. Research involving patients with chronic anal fissures, painful tears in the anal lining, found that a modified toilet position with elevated foot support and increased hip flexion was associated with reduced pain and easier evacuation. Not a cure, an adjunct worth trying out. The third is adding stable upper body support. When the body has more fixed points to push against, the effort distributes across the whole system rather than dumping onto the abdominal muscles and pelvic floor alone. Gripping a secure handhold, a grab bar, the edge of a sturdy vanity, and pressing down or out while bearing down reduces the isolated load on the pelvic structures. The same logic applies to pressing the feet against a stable surface in front of you. The critical word here is stable. Nothing that slides, wobbles, or tips over. And here is the point that ties all of this together. These positional tools are emergency exits, not a whole lifestyle. If every single trip to the bathroom requires a footstool, a grab bar, and a specific angle just to accomplish anything, that is your body telling you the root cause needs addressing, not just managed around indefinitely. Chronic constipation is not normal. It is not just how some people are made. Research consistently links chronic constipation to reduced quality of life, disrupted sleep, worsening mood, microbiome imbalance, and increased risk of certain gastrointestinal conditions. It deserves a real clinical conversation, not an indefinitely extended workaround. If constipation has become a regular feature of your life, here is what a productive conversation with your doctor might cover. First, fiber intake. Is your diet actually providing enough vegetables, fruits, legumes, and whole grains? Most Americans fall well short of the recommended daily fiber target. Second, hydration. Dehydrated stool is hard stool, and even healthy bowel contractions struggle with dry, compacted content. Water intake matters more than most people realize. Third, medications. Opioid pain relievers, certain antidepressants, iron supplements, and antacids containing calcium or aluminum are all known to slow transit through the gut. If you are taking any of these, your doctor needs to know constipation is an issue. Fourth, thyroid function. Hypothyroidism, an underactive thyroid, slows nearly every metabolic process inside the body, including gut motility, and is a commonly overlooked contributor to chronic constipation. Fifth, pelvic floor function. If dietary and hydration changes do not resolve things, pelvic floor physical therapy, and in some cases, biofeedback training, where sensors help you learn to coordinate those muscles correctly, has strong evidence behind it. After 45 to 50 years of age, muscle tone naturally declines, nerve signal transmission slows, and the cumulative burden of medications and comorbidities adds up over time. The bowel is not immune to any of this. Leave a comment below. How old are you, and does this topic feel relevant to your day-to-day life right now? Age genuinely changes where the conversation needs to go, and knowing what you are dealing with helps me build videos that are actually useful for where you are. Here's what to take away and act on starting today. Stop holding it when the urge is real and a bathroom is available. That is a habit, not a necessity, and it carries a documented downstream cost. Stop sitting on the toilet longer than the job actually requires. Put the phone down when you are done, not 5 minutes after that. Stop forcing it with heavy straining. If it is not happening, the answer is not more effort. It is understanding why it is not happening. If practical positional changes help in the short term, use them, but treat them as information that something needs addressing rather than a permanent solution. And if you see blood, experience significant pain, or notice a sudden change in your normal bowel habits, that is a reason to contact a doctor, not to search for a video that confirms it is probably nothing. It might well be nothing. A clinician is the right person to make that determination, not a search engine. Everything in this video is information. It is designed to help you understand your body better and walk into a medical appointment with smarter questions, not to replace that appointment or substitute for advice from someone who actually knows your full health picture. If this gave you something real to work with today, subscribe and leave a like. That helps this channel reach more people, and 300,000 subscribers is the goal. If you want practical checklists to go along with this, scan the QR code on screen. That takes you straight to my Telegram channel where they are all posted.